Oh, okay. Hi.
So, okay, this is a take two. We went live on my personal page first, so apologize about that. We already answered one question. We'll do another quick introduction, but we'll also share the video with the answer to our first question. So I'm Stacy, the owner of Starfish Therapies. I'm a pediatric physical therapist. I'm also going to be trying to monitor for questions that come in on the live and to share them. And sharing them to the panel, as well as some questions we've received ahead of time. So I'm going to go to our next person, Jessica.
Hey everyone, I am Jessica Oakland, pediatric physical therapist at Progressive Beginnings in Sheboygan, Wisconsin.
Hi everyone, I'm Kimberly Bradley, pediatric occupational therapist and owner of Kim for Kids down in New Orleans, Louisiana. I'm going to toss it to Amy.
Hi everyone, I'm Amy Whedon. I am a pediatric occupational therapist and I am the owner of Kidshine LLC, and we are based in Rowley and Amesbury, Massachusetts.
Hi, everyone. I'm Heidi Miller. I'm a speech language pathologist and oral facial myologist. I have the HMS clinic, which is a speech and language clinic in northern New Jersey.
All right, so we will reshare. We basically talked about a screening tool earlier and how we would play off, like what we would look for and when we would consider to wait and see and when we would consider telling somebody to go further or just to monitor. So we'll share that video. Again, it was on my live, on my personal. So, you know, if you guys want to just come visit me over there, feel free. So let's see, I'm going to be trying to pull up things, but one of the questions we got earlier was so a little bit more speech related for a mom who has a daughter who's 11 months old and she thinks she still has a tongue thrust. She chews her food but then spits it out. She told her pediatrician and said, oh well, let's wait until they're closer to 18 months. How do you guys, I know like OT and speech actually both deal with food, so like how would you guys respond to this? I think Jessica and I are going to listen and learn.
I'll start with this question. Truthfully, that tongue thrusting pattern, for as long as a baby is on a bottle, that's the way that they primarily take in food. So I wouldn't be so concerned about that tongue thrusting pattern at 11 months per se. As the child gets older, yes. But I would be concerned about the fact
and speech
that
both deal with food. So like how would
food. So I wouldn't be so concerned about that tongue thrusting pattern. What happened? What's going on? As the child gets older, yes.
Oh,
but I would be concerned about the fact.
Okay.
What happened?
Sorry, I was trying to find the feed of questions and I turned it on. Sorry, guys, you're getting to watch me do comedy of errors. So keep talking.
Okay. So I wouldn't be so concerned about that. As the child gets older, yes, the tongue thrust pattern is considered disordered. But I would not be thrilled about the idea of the child chewing and spitting the food out. That would probably prompt me to ask the family to go ahead and take the child to an ENT, make sure that there is enough pharyngeal space. I would want to know why that child is trying to create more pharyngeal space. And sometimes it could be because the tonsils are too big. So I would want to go ahead and make sure that I would check for, you know, what we call upper airway resistance and see whether or not that's one of the reasons why the child is spitting out the chewed food. The reason why Stacy had mentioned that it also falls into the OT category is if it is a sensory reason within that inner oral cavity of the child not being able to process those sensory changes with the food. And so certainly Kim and Amy can address that.
Yeah, and also what other symptoms and signs are they showing? Are they gagging in certain textures? How are they doing with liquids and taking in those liquids? Is there a lot of spillage coming out of their mouth? Are we dealing with some oral motor weaknesses? But mainly from an OT perspective, we're going to be looking at the sensory component, if they can tolerate a progression of textures and what their response is to those types of textures.
I also like to ask questions more holistically about what's going on with the sensory systems. And so ask, you know, are there any other difficulties tolerating things like, you know, toothbrushing or cutting hair or cutting nails, things like that, that also can indicate if there's a tactile defensiveness in other areas. And then also just look holistically at how they move around their area and space, if they're sensory seekers, if they're, you know, more just sensory overreactive, and kind of look at it from that perspective.
That's all.
I'm sorry. I was
No,
going to
go
say
ahead.
when
I
you
was just
say
gonna say that's all great. I'm listening.
yeah, it is. When you say sensory overreactive, can you just define that better for the parents?
Sure, absolutely. So if you have an overreactive sensory system, then you can demonstrate signs of defensiveness, of being sensory defensive. And so that might mean that you'll see things like getting upset when they're eating certain foods, or getting upset when you're putting clothing on them, or you might, try to wash their face and they'll react to that water on their face. So really just being oversensitive and overreactive to stimuli, because that stimuli, that touch can feel very aversive to the child.
Thank you.
Okay, we had a more PT related question come in. So one that we get a lot, and actually a bunch of us just did a crawling week anyway. So crawling comes up a lot, like if it's important to crawl, if their kids should crawl. We hear a lot of times like doctors are like, oh, let's just wait, or it's not that important, or maybe not even doctors. I'm actually part of a parents group. And a lot of times we see parents saying, my kid never crawled and they were fine. So I guess, what are your thoughts about when a child should be crawling, or if it's okay to wait? Yeah, I guess, what are your thoughts?
So I think it also kind of, as we've kind of said, I'm sure you guys have kind of seen a theme, that it really depends on what else is going on with that kiddo, and so is the child who is looking to start crawling, how are they at sitting, right? Do they have a strong core at sitting? Are they able to sit up with good posture? Can they reach for a toy and shift their weight a little bit? That's going to tell me how well their core stability is. If that child's really in kind of that slumped posterior pelvic tilt and really doesn't show the ability to move in and out of that like good pelvic positioning, they might not be ready to kind of move into that next step of crawling, because they don't have that true foundation, right? It's all about that base, classic song, right, as well. But that you really need that good foundation to be able to have that mobility, right? Stability drives mobility.
Yes.
And without just that base foundation, they're not going to be ready.
I will jump in here and kind of counter argue a little bit, in that I see a lot of kids that I call them professional sitters. They're the kids that are like, I'm good here. Like, don't make me move anywhere. Like, I can get things really far from my reach, but I'm not going to move out of sitting. I don't know how to get back into sitting. And I would say that if you're seeing that and your child's not transitioning or looking to transition, or you're not seeing a lot of like mobility at the hips, so like where they're kind of going from that wide ring sit to maybe like a more side sit, so both their feet are pointing to the same side, that would be another cause for concern.
Almost as if they feel like stuck, would you say, right, Stacy?
Yeah, stuck. They're just like perfectly content. Most people just are like, they're happy, they're content. Like, I like it. Like, I know they're supposed to move, but I don't know that I need them to move. And so and my just thought on crawling is like, I think it's important. If they're not doing all those things, I would work on it. Or if they just only want to stand. And I, a lot of times tell parents, I'm like, well, how are they getting to standing? Like, are you putting them in standing? So I would avoid that. Like, I'm never going to stop a kid who's going to get over and get up into standing, but I'm not going to just put them there. And if they do skip crawling, I'm going to make games later to play. But I think if they're really preferring standing or sitting very still, and just very content, like, then I would not wait and see. Like, you want those early transitions. That's how they develop motor planning, and motor planning drives all the later movements that they're going to develop. We did get a question on Facebook Live. People have more to say about that. That's fine, or we can come back to it. But somebody wants to know, what is our opinion of ABA involvement in feeding therapy, especially since they have no education regarding oral motor structure or function? It's a person who's a speech therapist and the mom of a child with ASD.
That's a loaded question. Feeding is very, very complicated. And, you know, I love it, but it's very, very complicated. It's 26 muscles to swallow, 6 cranial nerves, sensory systems. And when you have a child with ASD, then that sensory aspect is so typically, I mean, you know, it makes it so much more challenging. And because the sensory system, sometimes there's dysfunction there, it does not allow the children always to move through their, you know, earlier milestones with feeding to have more complex textures. So therefore, you then can have some motor interruption as well. I wouldn't, if there is a very involved or like motoric component, in other words, the child really does not chew very well, doesn't manage mixed textures very well, has any kind of coughing, gagging, is not clearing the bolus very well, then certainly no, an ABA therapist is not the person. They need to be with a speech therapist that has specialty in feeding, or an occupational therapist that has specialty in feeding enough to be able to manage that oral phase. But if it's a child that responds well to the structure of ABA and feels safe within those confines, feeding therapy is also a lot about the relationship and, you know, learning to feel safe with food. So I certainly could never sit here and say absolutely no ABA therapist could ever efficiently and effectively treat feeding, but I can say that feeding therapy is very complex, and, you know, it should be treated that way.
But do you think, Heidi, if maybe the ABA therapist maybe would be an expert person to carry over a home exercise program with really good consistency, since usually the ABA therapist might be the one that's providing care with routine, that maybe that person would be a great person to teach a home exercise program to, and that maybe they can come with to that speech or OT session and get that education right from the professional?
Absolutely. And you know what, feeding, especially like the program that I teach or that I created, is all about that collaboration, you know, the collaboration mostly with the parents, because if, you know, the parents and that feeding relationship, but if the child has a really good relationship with the ABA therapist, like they really enjoy each other and there's a respectful, which I've seen before with some of my kids, that collaboration could be amazing. So it really is so individual. It's such an individual case by case.
So there's been some like follow-up based on your answers. So first she said like she didn't really feel like they took all the factors into consideration, but she also said that in New Orleans, ABA centers do feeding therapy at the clinic. So
without a speech therapist present. All right. Well, I don't know about that. Kim
but
would know
I
better.
Was going to ask the same question Jessica did about like, could they be great for carryover? Because I do know that they're really good about a structured approach.
Amazing for carryover, and another person part of the team, 100%.
Yeah. We got another, go ahead, Kim.
I mean, you know, every ABA place is different. Every ABA person is different. I know ABA people that are going to consult with us for feeding, and I know ABA people that are not going to consult. And I mean, it can go the same for anything. It can go with W sitting. It could go with holding a pencil. Like there's different thoughts on how we approach things. I'm looking at a completely different thing when a child is holding a pencil, and ABA is tackling it from the behavioral.
Absolutely.
And so I feel like what type of feeding therapy are they really doing? You know, I mean, I know ABA therapists that have, I mean, pretty much tried forcing food down kids' throats. It's, you know, it's very different things to look at, and it should be a multi-team approach,
disciplinary,
the whole child to treat. So we got to look at oral motor, we have to look at sensory, we have to look at postural control, we have to look at behavior, we have to look at cognition,
psychology, absolutely. And we have to look at the family.
Yes. And we had somebody on here say that they are a BCBA and that they have collaborated a lot of times with speech therapists. So I think that is the big key, is if you're working with ABA,
collaboration,
to find a center that is willing to collaborate with the other professionals. Like
When I have an ABA person that is willing to collaborate with me, it saves my life. It's like when I have an OT that's willing, that treats with me, because I do my speech stuff and the behaviors are managed, and it makes treatment tremendous. You know, when you have a wonderful collaboration among therapists, it makes a world of difference. That's why I said it's a loaded question, because it's really so individual. You know, look, if you have a really motorically involved feeder, no, it's not going to work, because you need but if it's but those collaborations can be priceless.
But yeah, I mean, I also look at like, just in general, like what am I teaching the families to do for carryover? So anything I'm teaching the families, like I should be able to teach somebody that's going to be able, like, spend so much time. Like we actually had a family that their ABA therapist was having a hard time getting the child to participate in virtual therapy. And so the ABA therapist asked to like observe our session because our therapist was having luck. No, it could have been luck of the draw, but like that we love, because when you have collaboration and you have professionals willing to collaborate, it always benefits the child and the family.
I totally agree. 100%.
We have gotten some more questions. So the person who had asked this question, they had the experience of force feeding. So I would probably recommend looking around to see if there's maybe a different person or willing.
We never force feed. No, we never force feed.
Okay, this is about bilingual.
That person can DM me.
Yeah. Feel free to DM Heidi. So I keep losing it. So daughter's 27 months and at home they speak Italian to her. She fully understands both Italian and English, but speaks mostly English. Can this generate some type of confusion to her and maybe have her get fluent with a little delay, or are we doing the correct thing? I can tell you what I've heard in the past. Again, I'm not a speech therapist. I've heard that as long as you separate the context of the language, so like maybe mom speaks Italian, dad speaks English, or Italian is spoken only at home and English is everywhere else, or the kitchen is Italian and everywhere else, but not like intermingling in the same conversation. I've heard that can cause the challenges, whereas like making them separate and distinct can be easier. Now that is what I've heard with doing research. I'm not the expert, so I'd love to see if Heidi has any thoughts.
So they used to say that there would be a little bit of a delay with speech with the bilingualism, but then there is a catch up. Like by the time the kids are 5, there's a catch up. And there are now, I believe, this is not my main area of expertise, so I want to be very clear on that. But now they believe that there are actually benefits to a bilingualism. There are a couple of times that I do not suggest that. If I have a child that is severely apraxic, has difficulty with motor planning, while it is very good to learn the different kinds of oral shapes, I prefer that they sort of in the beginning learn it in one language, because I think that it's going to pose more of a challenge. If I have a child that's really struggling with language, I think it can be very difficult because word order, syntax, this, the other. But what I will say to families, sometimes I have families that come and the families all speak one language, but like the nanny speaks another language, but there's no cultural relevance within the family. So they'll have their child learning a language that really the grandparents don't speak, the aunts don't speak, that nobody else speaks. And then I say, this child is already delayed and your child's learning a language that nobody else speaks. Let's keep that. That's not necessary. But when I have a child that comes and there is a familial aspect to it, and that was my upbringing. I mean, I know that it's personal, but my father was from Italy and my grandmother didn't speak English. And the only way for me to communicate was to learn Italian. So what I say there then is a lot of times I'll say to family members, like, keep the academics in English, because they're going to go to school, they're going to learn their numbers, their letters, their shapes, their colors, but like keep the food, the I love you, the, the stuff that like, the mushy familial stuff in that other language. But if you have a child that's learning another language and there doesn't seem to be any kind of a delay and it's working, then they do say that there's really no consequence to it. And in the end, it's a huge benefit.
I wish I knew another language. I know lots of words in multiple languages. Like I can say I am hungry in Swedish. So, I won't start.
Swedish is a hard one.
Okay. So there was another question about stairs, about a child having the strength to go down the stairs, but seeming really fearful about going down them. What do you?
So, I mean, one thing as from an OT's perspective that I'm going to be wanting to know is, well, how old is a child and where should they be at developmentally with being able to go downstairs? But then also if they're showing some gravitational insecurity, which as OTs, what we consider that is basically fear of feet being off the ground. So are they fearful when you pick them up? Are they fearful when they're on a swing? Are they fearful of getting into the car? Where are the other fears observed? Are they fearful because the stairs are more open versus closed? I've had many kids that can go down stairs that are closed, but not that are open because visually it's very frightening. So again, looking at that, looking to see at what other environments they're fearful on. And then from the sensory perspective, do they have any other sensitivities, either under or over sensitivities to other types of sensory input? We consider when going up and down the stairs as movement, the vestibular system. So I'd want to see, is there any other tactile sensitivities or oral sensitivities or sound sensitivities if we're dealing with a sensory component. One other aspect that we can look at strength-wise is if the child has enough muscle tone and strength, are they dealing with more of a postural insecurity that no matter, where they move in space, that they just do not have the strength to be able to do it. It's very different from a sensory standpoint from being fearful of going downstairs. And Amy, you want to add to that?
Yeah, and just to, also kind of piggyback off of what you're saying, body awareness can also have a lot to do with that too. And, there's some kids that from a body awareness perspective feel better when they are making contact with the wall or making contact with the floor, or even standing too close to another child is how they're trying to figure out where their body is in space. So they can have challenges with that, which will impact their ability to comfortably and safely walk up and down the stairs. And then the other thing to look at is depth perception as well. And that's something that, I've observed kids in preschools and other schools walking up and down the stairs and been like, oh, okay, so this potentially could have a sensory component, but I wonder about their depth perception as well. And that can be very scary if you don't have depth perception to know where you are in terms of going down those stairs.
And
is that a visual thing? I'm sorry. Is that a visual thing?
Well, I was about to say, and depth perception goes with binocular vision. And so one thing I've always tried to get my families to do immediately when we're referring, when I'm evaluating them in therapy, is to have they had their vision checked. And so definitely, they should have vision checked immediately as a first thing to be able to look at that and make sure that their binocular vision is okay, because if not, it could have an effect on depth perception.
And from an ocular motor perspective as well, too, you really want to make sure that the eye muscles are all coordinating so that everything is able to be processed from that perspective.
And you can do an eye exam as early as a year, because my child had one. Because
I was just going to ask that.
We went and they dilated his eyes, and I'm amazed that they were able to get I was like, what can you even tell that you're doing? But
what made you go at a year to get his eye exam?
The pediatrician and I both noticed that it looked like one eye was off, but we could never tell which one. And so we had a virtual exam early on in the pandemic. So the pediatrician did some type of test, and again, it was sort of inconclusive. So then they did a virtual, and they didn't see anything necessarily. So they had us follow up at 1 year in person. And they didn't find anything. So they said part of the thing with babies is that they have extra skin and stuff. So it may not be what we would call a lazy eye at that point. It could just be morphology, and it shouldn't look like it's getting worse as he gets older. And a lot of times you can see it in pictures. So that's usually the first place parents, what we would call a lazy eye at that point. It could just, geez, okay, sorry.
Stacey, I also wanted to say too, I just recently wrote an article about vision exams and ages and what can be prevented. Oh. A lot of things can be remediated and fixed if poor vision is caught early. So I'll see about sharing that too.
Share it in the event. That would be awesome.
Yeah, that's
I was going to add to that conversation about stairs, and it might have to do with depth perception, but a lot of times I tell parents that start with one step going down, because think about the difference of putting a child at the top of a flight of stairs versus just going down one step. And so like, let them get comfortable with that and then maybe go up 2 steps and have them go down the last 2. So like you might be carrying them part of the way down the stairs or letting them crawl down, but so build it incrementally that way. And that could be something else that has to do with fear, just because it's like, oh, that's a lot. You know, and some kids are bigger risk takers than others. And so like, that's where I've seen it sometimes.
I think so too, kind of adding to what Stacy just said, is taking the kiddo out of the stairs, maybe bringing them to a playground.
Morphology,
See
and
if there could
like
be some kind of playground that you can put them up on a raised height, and that way see, are they still fearful on a different surface? And sometimes just putting the kiddo in a little bit different environment to work on some of that, especially at a playground, the steps are a little bit wider, they might be a little bit shorter versus your like classic 6-inch stair. So it might just be a nice place to practice doing the stairs, but also a great place just to play with your kiddo too. And it doesn't even feel like work then, as they're just playing, but you're working on that kind of fear of heights, but also kind of the fear of stairs, but at a playground.
I saw a question that kind of is always a loaded question, I feel like, but it might be like relevant for all of us to talk about W sitting. Is that something, if their kid's doing it, should something be done about it? Is it ever okay? Like, should a pediatrician be concerned when they see it? Like, how do you guys approach W sitting?
I think a big part of it is one, how old they are. I think another really big part of it is the amount of time they're in W sitting. Like, is that their preferred sitting position always? Like, are they, if they are sitting 100% of the time, are they sitting? Are they in W sitting? Or do they use it and can move in and out of it? My daughter's almost 3, and I'll occasionally see her in a W sitting. And as a PT, I'm not the, oh my goodness, that's terrible, because I know that she's able to kind of choose other positions as well. She just has that hip mobility that allows her to get into that position, versus a parent that may describe that your kiddo is W sitting and they do W sitting all the time. W sitting is a wide base of support. And so again, kind of going back to that core control, do they have enough stability to move into or maintain a sitting position other than W sitting? If the case is no, and they're truly choosing W sitting because that is where they feel the most stable, that's when I would refer out and truly get a therapist to look at that and really give you ways to work with that kiddo in a professional setting.
Yeah, I would add to that that my biggest challenge with the W sitting, because it's actually been shown it doesn't like increase hip dislocation or anything like that. It actually plays a bigger role in the lower leg and like causing the rotation in the bone there, the tibia, as opposed to the hip. And some kids do have, based on their bony formation, it is a more comfortable way to sit, but like you would have to go get that checked out.
What's the I'm sorry, what's the tibia?
The tibia is the lower part of the leg.
Part? Like the knee or the ankle?
Between your knee and ankle, that bone.
Oh, that big bone.
Your shin.
Okay, your shin. Okay.
Sorry.
All right. I got you all, none. I have
great clarification, Heidi.
But so the reason I struggle with W sitting is, again, if they don't have the core stability, because when they sit like that, what it does is it turns off all of those muscles in their core. Like it tilts their pelvis back and they can kind of just like hang out there. They don't have to like stay upright and work on rotations and stuff like that. So again, it's about that. And maybe it's getting them off of sitting on the floor. Like maybe it's getting them in a little booster seat or something like that to help. Like I would rather see that than like maybe some of the like, that is the only way they sit. Just got a great point about like, if they're moving in and out of it, it's not a big deal. It is a sitting posture. It's just if they're staying in that all the time, it's about moderation really. Anyway, I'd love to hear other people like OT, speech.
Yes, Stacey.
Yeah, go ahead, Amy.
I think that's it's a great point and a huge point to really look at it from a perspective of, does the child have that postural control, and does the child have that core stability? And, we all kind of fight over, who's in charge of postural control? Who's in charge of core strength? And I think we kind of all are, for all different reasons. I mean, it affects every area of a child's development. And I remember being in school and hearing, core stability, proximal stability leads to distal mobility, meaning when you have a strong core, you can use your hands. And so here we are again as OTs talking about having more dexterity in the hands and more ability to do things that kids need to do with their hands in the classroom, writing activities, bilateral coordination, cutting activities, buttons, zippers, fasteners, all of those daily activities of living. And so we have to have that core stability first. So if W sitting is indicating that the reason why is because the child is trying to increase their base of support and get increased core stability, then we want to look at what that decreased core stability is going to mean for us and how we can help that child.
And a main reason why we really don't like W sitting is one, I mean, it's not great on the joints and, promotes more joint laxity, which we don't want, but it also limits their movement. You have less trunk rotation, less ability to transition in and out of that movement, less ability to explore and play. And so W sitting is just so limiting with that. And so that's why we don't want them spending a lot of time in W sitting.
I think the other big part too, kind of going off of what Kim just said, is in W sitting, both of your hips are in the same position. And so they're in what we'd call kind of internal rotation position, versus if they are in a side sitting position. So 2 feet to one side, your hips are each doing something different. And it, again, as we've kind of all been saying, it allows that fluidity of movement. They can easily get in and out of that pattern. It also then is going to allow them better movement looking at transfers, right? If you'd sit on the floor and you would go to stand up, you'd want to go through one knee up to push up into stand versus putting hands on the floor, pushing your butt up into standing, and then coming up tall in an erect posture. And so that kind of disassociation of one hip doing something and the other hip doing another can already be seen in sitting. If W sitting is their preferred position, they are not disassociating those two hips, which you're going to see in other movement patterns.
Right. They also tend to move in a lot more
together.
Forward and back position and so honestly, in terms of motor development, this forward and back is like the first level of motor development. And then once you kind of have that, you like add in the side to side, because now you have that under control and you're going to move this in. And once you have that under control, you add in the rotation. Well, that W sitting, they tend to just move in that forward and back. And if you watch them get in and out of the position, it's straight back, as opposed to adding that rotation into the hips, like we were talking about earlier with our like sitters, because even ring sitting, that wide ring sitting, so when the feet, so the opposite of W sitting, like the legs are just widely turned out in a big circle, that can also be just as limiting if they're not getting that mobility so that they can dissociate the hips. So again, when I see challenges with transfers, is always let's not wait and see, because to me, it impairs motor planning. And again, as I said earlier, motor planning impacts all areas of development. It's one of the main building blocks. And so that ability to explore movement really helps kids to develop that. And just to trial and error, let me fling my arm here. Oh, what happened? Okay, let me try again. Like that, they're taking in all of that information and learning from it and refining. Anyway, sorry, I go off on tangent, so I'll just
Well, the motor planning piece, I agree. The motor planning piece is sometimes, at least in my world, it's a doable remediation. I love it. I do it all the time, but it can be a little bit slower, a little bit more challenging. So it requires a little more effort. So if you get in there earlier and you can, try to rework some of those motor plans, or at least start to help to teach some of those motor plans, there's a lot of efficacy for that.
All right, so we have a follow-up question on this now that we've talked about motor planning. It just says, so that being said, apraxia, motor planning. So I'm assuming they're like, what if kids have apraxia or dyspraxia? Okay. I mean, are there...
Maybe Heidi, can you define to some of the parents what apraxia is?
I certainly can. So apraxia is when the children have essentially, it's a disturbance in the movement. So it's really, again, it's a motor planning problem. It can be somewhat overdiagnosed. Really, the incidence, I don't want to get this wrong, but I want to say I just wrote it out. Incidence of apraxia. I think that
you can share the number.
I'm going to share the number after because I don't want to get it wrong, but it's really not that high. And so when you have a child with apraxia, typically some of the red flags that we see low phonemic repertoire, meaning they're really not saying that many sounds. We do not see a lot of different vowel shapes. A lot of their vowels will sort of sound the same. Sometimes the children are sort of, in my experience, sometimes you'll hear that they were sort of more quiet babies. They definitely, children with apraxia have, few words. They don't usually, have again, a very big phonemic repertoire. And you're not talking about the independent sounds when you're talking about apraxia. You are talking about the transitions of the sounds and the movement of the sounds. So you teach it in trying to teach the children different oral postures and then getting them to generalize it. So that differs from something like an articulation disorder or a phonological disorder, where the children have just delayed sound sequences. And there, the sounds are going to be essentially always the same. In apraxia also, there are inconsistencies. And why are there inconsistencies? There are inconsistencies because it's coordination. So the children sometimes they get everything working together and coordinated, and other times they can't. So the precision is off. You're not getting precise movements. With articulation, what happens is the child, let's say they're, fronting a sound, they're making a G sound and they're turning it into a D sound. They're almost always taking their G and they're turning into a D. It's more predictable errors and you're dealing with the sounds. So they are very different kinds of treatments. Very often with children with childhood apraxia of speech, you are going to do smaller like therapy, like 30-minute therapy sessions multiple times a week. And you're going to use I use the DTTC method, but I also use David. I use a bunch of different things, and you're going to stick with sort of smaller sets of words, focus on vowels, different postures, and you're going to work on those transitions. Whereas with the articulation and the phonological, you're going to sort of be more sound focused. So I hope that clarifies it. And that's apraxia of speech.
So apraxia though can play into all other areas because it truly is a challenge with what is
the
related from the brain to the body. And so
exactly the message.
Yeah, because there are some diagnoses that have or apraxia involved with it. And so like one of the examples is we've had kids where I've gone in and seen an evaluation and they're like, or seen somebody else's report and they're like, they don't follow commands. And it's like, well, no, because they might understand what you're asking them to do, but like they can't get that message through. And so where I've seen that like they could do it. So my example is always like, okay, so there's a glass here. They could see the glass and pick it up. Now I could say, pick up the glass. And that's a whole different set of processes that happen. And what tends to happen, and I'm guilty of this, is like, okay, they didn't pick up the glass. So I'm going to say, pick up the glass, pick up the glass. And every time I say it, it's starting that process over for them. So it's very interesting, like trying to like frame things so that kids can figure out how to do it or make it more, volitional. Yes, I saw that there was the question about that was on there and I was waiting till this finished, but anyway, sorry.
Yeah, well, that volitional piece comes in because as we practice, then it ends up, then they're able to access it better. And I kind of give that riding a bike example, like, in the beginning you can't do it, but then when you can do it, then you can access it. So we try to bring them so that they can access more motor patterns, from a speech perspective. It is so interesting to watch the motor stuff from when I co-treat with my OT and, we're with the dyspraxic kids throughout their body, like she'll put them on a swing and then the kid can't get off the swing. She's like, look, the kid's not going to be able to get off the swing. And the swing is literally an inch off the ground. And I'm like, what do you mean she can't get off the swing? She's like, Heidi, she won't be able to get off the swing. And she's right, because she does not know how to plan to get off the swing. And I'm like, but it's true. It's fascinating.
Mhm.
But the most important takeaway is that we can help.
Yes.
We can help these kids. It is amazing. We have the tools to help these kids. And to watch them make those changes is like, it's heartwarming. I mean, it's crazy. It's really is.
Yeah. No, I know. Sorry, I was looking at the chat. It's amazing. And especially like when there's consistency and like, I love it. Like, I don't know, like, and when everybody's working towards the same goal, because it impacts every area of life. So there was the question, sorry, I'm going back a little bit.
From an OT standpoint, when you guys see the kids with apraxia, I find, and obviously this is a gross generalization, but sometimes, see, I don't see it as much with speech, but sometimes if there's like almost like a behavioral control, like it almost presents, I don't want to say behavioral, but like a fight or flight. And do you know what I'm talking about? Can you explain it better than what I'm saying? You guys know what I'm saying or no?
I think that, sometimes when we look at apraxia, or we look at generally at praxis and think about how all of the sensory systems are involved in praxis. So in order to do something that involves multiple steps or be able to process all that information, the child also needs to be able to filter all of the sensory information from their environment in order to do what they need to do. And if the sensory stuff is getting in the way, and again, we're talking about a kiddo that maybe is overreactive or underreactive, especially with the kids who are overreactive or overresponsive, they can go into a fight or flight response if they are overstimulated or if they feel like the information from their environment is aversive. So sometimes you might think you're doing something that's totally innocuous, like tapping a child on the shoulder. But if they are overstimulated, they can go into a fight or flight response. And when you have a kid in a fight or flight response and you're asking them to do something, whether it's something as simple as, hold a Superman pose or walk across the room, they're not going to be able to follow any of those demands if they've got all of that bombardment from a sensory perspective.
Okay, so yeah, I sometimes see that.
I related to, I don't know if anybody else that's a parent can relate to this, but like at the end of my day, if I am like trying to focus on something, and I'm never good at the end of the day anyway, but like, and my little one is like crawling, like even tonight we were preparing for this and I needed to focus and it had been an all day thing. And like, he was trying to like sit on me. And I finally was like, I can't focus on this and have you on me because I'm at the point where I can't put things into compartments. Like I was but I could manage it. It's just when, we all hit points where we can't manage it, but it doesn't get in the way of our everyday function. Did I summarize that okay, Amy and Kim? I'm not. Okay, because I'm not good with overstimulation either.
None of us are.
There was a question on here. So as a parent of a 1-year-old and 4 days, happy birthday. Congrats, mom and dad, for
so exciting.
getting through the first year. And listening to all of us so far, I wonder, how do I know what things to be looking out for at certain ages? We love our pediatrician, but only see her every few months. Do you all have a book you would recommend?
I think instead of recommending a book, not that a book isn't great, there definitely could be, but I would say honestly, jump on Instagram, jump on your social medias and follow us, follow therapists in your areas, as we are constantly sharing content that are those kind of like in and outs of not only development, but just things to kind of be watching for, as things that we may see not only in our own kids or of course in kiddos that we see for therapy, but truly do just want to share that extra knowledge to really avoid this, well, I don't know, since of course no one knows what you don't know, and there is no manual for parenting. And I think any parent always wants to give their kiddo and set up their kiddo for success. And so truly our goal as providers and wanting our knowledge known and accessed, social media has really been a great avenue to really share some of that information in small bits and pieces with cute videos and photos and stuff like that, to even just make your brain think and like, is my kiddo doing that? And if not, it may be okay, but if not, it may not be okay. And so reach out to reach out to that professional, reach out to that therapy clinic and talk to a therapist. Again, worst comes to worst, they're going to say, hey, it really is okay. That is normal. But it might also be that it may not be.
And to add on to what Jessica's saying, and I also posted this on our Facebook event page too. I just did another article about what you can do to help intervene and help the warning signs for autism. And one of the biggest things I tell all of my friends with babies, all of my new parents, is to know the milestones and to go to the CDC. They have a Milestone Tracker app that you can keep on your phone. There are actual videos that
literally, and you can print it. It's like right here.
So you have it on your phone. It has for all of the areas that we are talking about. And then you can see for yourself. They give video examples of what your child should be doing. And what that should look like. And then you can say, sometimes, yes, they're doing this. No, they're definitely not doing this. And then you can look and see, oh, is speech kind of a weaker area here? Or is the gross motor things not coming along as well? And I'm always trying to empower my parents that you can go and seek out a PT, OT, or speech evaluation without your pediatrician saying, yes, you need to go get it. Call your
Unless you have
contact.
an HMO.
Well, yeah, but a lot of them for us, we just need the prescription from the pediatrician and we take care of that for the families. So it's advocate for your baby, seek out additional an evaluation just to know if it's peace of mind. No, he's fine. He'll catch up. So like I said, I posted that in the Facebook event. So it has all of those resources on there where you can check your baby's milestones.
I would also say, in addition to all of our social media followings, pathways.org is another great one. In addition to
I was just passing that into the comments, Stacy.
Yeah, I mentioned
pathways.org
in the article also, so that's in there.
They're another great resource. I mean, I'm going to self-promote for a second. We have little ebooks, but only for gross motor up until 9 months. We're working on up to 12 months. But I mean, you look at the people you like to follow and also see what they're doing, or reach out and ask questions, because also questions helps us know what people are looking for too.
That's true. Yeah. I mean, I'm the mom of 3. My kids are older now. But I think the other good thing is, like, if there's a mommy group, and I'm not talking a huge extensive mommy group, but if you have 2 or 3 mommy friends or people around the same, now it's getting nicer out. I recognize that it was during COVID when you had this child. And so you weren't able to go to the little gym class or the little singing class, but now hopefully they might have something like that in your, even doing outdoors when you go to the park. If you see somebody around your kids' age, oh, how old are they? I never want to say compare because it's an individual, but at the same time, a little bit, when your child is around other kids and you sort of get the sense a little bit, talk to your friends. And a lot of communities have mom groups within their communities, so when you join that, even if you're not one to, I don't really like to comment so much, for me personally, but even just, you can look and you can see, what people are doing. Parents have gut intuitions, there is an intuitive piece that parents have, and you follow that. And even if your doctor is go wait, and so many of my closest friends are doctors and they're phenomenal, but sometimes they're looking for pathology. Their concern a lot of times is pathology, not that it's not development. Of course it's development too, but sometimes they're there and they're looking for some of the other stuff. So as parents, follow that intuition. And, if you have a couple of baby friends and stuff, when they're hanging out together, look and see, doesn't have to be neck and neck, but if something is so swaying one way or another, it should send a little bit of a signal.
Right. Yeah, Heidi, I was going to, you took the words right out of my mouth. I was going to say, follow your instincts and don't be afraid to ask those questions and access, people who are available to answer those kind of questions for you. And again, my kids are also older, but when my youngest was born early at 34 and a half weeks, I called early intervention. She was a day old and I called early intervention. I said, can you just please look at her and just tell me that she's okay? And then they did, and they said she was fine and I was good to go. But don't be afraid to ask those questions. Don't be afraid to seek out professionals and get your kids involved in activities in the community. And there are a lot of activities in the community now that are run by professionals who understand child development. And again, not to totally self-promote, but we have a program that, allows kids to come do physical activity, and it's run by OTs. And so, we're doing it for fun, and we're really helping to promote, and we have therapeutic classes as well. But within our recreational classes, we are always here to answer parents' questions and say, hey, give this a try, or, take a peek at this or that. So we're always here to support. And that's something that you can seek out in your own community.
Certainly.
And of course, obviously, our kind of going with our talk tonight, and that we'd love to continue, is why you should not wait and see. And so really just hearing from us, but then also hearing from you guys, is that there's never a reason you have to wait and see. As Kim said, call your local clinic. We do the same thing and hear from parents daily, where you don't have to have an MD order to be able to be seen. We can take care of that for you. The first call can be directly to the clinic with that concern, and we will help you kind of travel through that path of how to get your kiddo the resources, so you don't have to wait and see.
Yeah, you can also reach out to your local early intervention providers. It varies by each state, but most early intervention you can get a free it's a free service. Each state has a little bit of different rules, but you can get an evaluation. And here's my thought is again, I have a 19-month-old, I'm in a mom's group. And if your gut is pushing you to ask a question of a bunch of other moms, there's nothing wrong with getting seen. It's just again, nobody's going to care when your kid's older if they went to PT for crawling, or how old they were when they rolled over. The goal is that we want them to be able to keep up with their peers when they're able to play in school. And if they need a little help to do that, then that's okay. And the sooner you get it checked out. So if your gut is leading you to ask this question of somebody, get the peace of mind rather than continue to wonder, because everybody's always going to share their experience of their child, but they don't know everything that's happening with your child. And so you can get that. We've done plenty of times where we're like, you know what, they look like they're doing good. Let's check back in a month. If you might be having concerns, so let's check back in a month and make sure they're just continuing to progress. They had maybe these risk factors or just your gut. So again, trust your intuition.
I think we have a question here. Mom has a 22-month-old that is dropping consonants. Truck is saying trust. Snake does not say the S. As a mom, I know what he's saying, but his grandparents are telling me that they can't understand him. Should I be concerned? I don't want to miss anything. So what your son is doing is what we call final consonant deletion and cluster reduction. So cluster reduction typically goes away. Well, honestly, they say 2, but I don't really agree with that. And then final consonant deletion by 3. So your child is 22 months. I would say at 22 months, it's way too early to be not way too early, but really too early to be tackling phonological stuff. If he is, putting words together and saying a lot of words and trying to communicate in that regard, I would not be so concerned about these patterns per se. That said, after his 2nd birthday, if you find that he is still, really cluster reduction isn't supposed to be gone until 3, but I wouldn't want him at 3 still leaving off the ends of his sounds. So I would say maybe 2, where are we now? We're in May. So June, May, June. So then I guess he's turning 2 in June. I would say probably September. I would probably check things out in September if he's still pretty unintelligible. So that's a little over 2. But honestly, this is a phonological thing, articulation. This isn't a big, it depends. If he starts to get frustrated, then, you're not going to want that.
Isn't there age ranges that by this age they should be 50% intelligible to people that aren't their parents? Or am I just making this up that I read?
No, you're not making that up. You're not making that up. I was
that
going
could also
by
be
the
good
phonological.
Refer to too, because again, as a parent, I understand. I have to look for context sometimes because
of course he's still so little. Right, he's still so little.
But yeah, so
it also matters how many processes they're using. If they're using 4 or 5 simplification processes and you just have no idea, look, a young 2 is a young 2. A lot of people don't understand a young 2, but in the speech world, 2 to 3 goes really quickly. And by 3, kids should be understood. So it's kind of like it's a delicate, it's delicate. But something like this marks a phonological thing. This doesn't make, this is what, I mean, the keys putting together TR, like tra is hard to say. So that's my 2 cents from there. I would have him screened in September.
We got another question, just a curiosity question. Are we seeing widespread developmental delays because of the pandemic? I mean, in terms of gross motor, it's hard to say, but I mean, I would love to hear you guys talk, because I think that there's areas that you guys are handling more so.
Self-regulation and emotional regulation and anxiety are big right now. We're seeing it so much more. We are so busy trying so hard to help so many kids who are just trying to figure out, one day they're at school, the next day they're on Zoom, the next day they're home, then they're in quarantine, then they're back. It's a constant change. There's no consistency, there's no routine, and there's so much screen time, and there's so much fixating on the screen. There's not a lot of hands-on, there's not a lot of moving your body, there's not a lot of social interaction. And so from so many different perspectives, but specifically from a sensory perspective and a social perspective, it's just a really, really challenging time for kids. And
I also think that we can't not kind of just talk about the mental health side of things too, as often you have change that happened quickly, right? We went from everything being okay to everything not being okay in a very short time, and kids thrive off of a routine. Adults thrive off of routine, right? Like we like having some kind of routine that we can grasp onto. And so when stuff like that doesn't seem tangible, and as Amy said, when it's kind of seems either taken away or not sure what going to expect next, that can put someone to a sense of anxiety, or not being able to see their peers or have that social interaction, or not knowing the why because it just can't be. That's hard for a kiddo to process.
And on top of that too, a lot of kids that what we found is in March last year, at the end of the school year, teachers were telling the parents, oh, we'll wait and see. Well, now we're waiting and seeing, we're a year later. And so kids that we should have seen, in the summer or in the fall, waited way too long to get intervention. And we've lost so much crucial time within a year. And so the kids have not made any progress, those kids that they were waiting and seeing back then. And so that's what we're seeing now.
That actually leapfrogs into this other question that somebody said: is there an age that may be considered too late to seek help or therapy? And I tried to get a clarification, but I would say no, never. It's just
start now.
The rate of progress, slows down as you get later. Like, just think about little ones are so plastic, like that it does, like the earlier you start, the faster things resolve, but it's not too late ever.
And I think the other thing too is, as a kid gets older, they figure out how to compensate, and sometimes their compensations may almost hide something that's going on, where it may not have been evident if it would have been addressed sooner. But of course, with the therapies, that will be found, right? And that intervention will truly help guide them as well. It might just take a little bit more in and out to kind of figure out, okay, what is that compensation? What is that strategy? And then how to redirect that strategy to make them successful.
The impact of the pandemic has been so significant that, kids who need support are struggling more, but kids who didn't need support are also struggling. I'm going to pop in the chat a link to a blog that I wrote about things that you can do to help your child with a return to school or a return to normalcy. Simple strategies that you can do to support your child as they're returning back into normal.
And then there was a clarification about in regards with behavioral, is it ever too late to start?
So no, I mean, even our kids, you know, whether it's parents that come in and the kid is 11 or 12 or 13, they're like, I knew something was going on when they were 4 and 5 and 6. And every year I would bring it up to the teacher, like, he's fine, he's fine. But then as the kid gets older, you know, the gap starts getting bigger. And even if a kid is that old, you know, we're not talking about our little babies, there are still effective compensatory strategies that we can teach. We may not be able to remediate and fix as we could when the child was the baby, and the brain, we have all that neuroplasticity in our favor, but definitely be able to teach them effective adaptive strategies to be able to get through whatever they need to.
And I would piggyback on that with, I feel like I have seen kids that maybe have delays or challenges, just even like talking about like the apraxia and stuff, like in some areas, and maybe they haven't started. So like they don't have the strategies to adapt. And so sometimes those frustrations can lead to behavioral challenges where maybe it didn't start as a behavior challenge, but because of these other areas. So anyway, that was just my 2 cents.
We'll take it.
Yes. Yeah, I mean, so we have been on for our second attempt on for an hour. We are planning on doing this again. Don't worry. We're going to rotate who's hosting it. And so hopefully next time we'll go even smoother. We have so many topics that we like kind of had in our back pocket to talk about that didn't even come up. And again, feel free to message us, but look for us. I don't know when the next one will be, but within the next like month or 2. Yeah. So thank you guys. Thank you guys. This has been fabulous. And feel free to keep asking us questions. We'll be happy to answer or direct you to resources. So
Absolutely.
And then be on the lookout for the next event. We'll, of course, advertise it, promote it on our Instagrams and our Facebooks, and you guys can follow along with all the great content that we share.
Certainly. And if there's a topic that any of you want, then feel free to let us know that. We are happy to explore.
yes.
Thanks so much, everybody.
Thanks, everyone.
Yes. Thank you.